So the agenda for today is to really go over some outstanding documentation pieces that we have, to go over the quick orders, billing report, just have a discussion regarding the pain management tool scale, and just kind of confirm the medical service for this clinic. So as mentioned in our first design session, when our team first engaged with your sites, there were kind of conversations around using the current enterprise outpatient clinic note format as kind of a follow-up note type, but you guys wanted to add the advanced care plan and goals of care information, which would be important. And then during our first design session, it was brought up that having the bowel performance score and the palliative performance score would also be ideal as well. Therefore, our prototype was made inclusive of these of this information. So what we would really like to confirm is a couple of things today regarding the design. However, before we do that, I will go ahead and kind of go a bit more into depth about the current outpatient clinic note in terms of its functionality and just how and can where from the information is populated into the note. Can everybody see my screen of the outpatient clinic note?
It's very small. If it's possible to make it readable, that would be great.
Oh, let me try that.
I actually can't read that. Maybe it's just my old eyes.
Did that help at all?
No. I've got you as big as it can possibly be on my screen. Chantal, can you see? And Marcy, can you see that? Maybe I need to get my. Wait a sec. I've got another screen which is a bit bigger. I might be able to get that working.
Yeah, it's a challenging font, but if I full screen it on my big screen, I can see it.
My husband's stolen my cable to my second screen, so I can't use my second screen, unfortunately.
Is this a bit better?
Better, yeah, enormously better. Perfect.
Perfect. So, great. So this is our current outpatient clinic note with the additions that were requested. So we have our chief complaint, bowel and palliative performance score, advanced care plan, and goals of care. We have our history of present illness, functional history, our physical exam, which is inclusive of vitals and measurements. We have our lab results, our problem list, and past medical history. And then we have our procedure and surgical history and medications, and allergies and social family history, and diagnostics, imaging investigation, and our assessment and plan. So within this note template, as you can see, there are various headings that are being kind of populated from the outpatient chart. So I'm just going to go into the outpatient chart and kind of briefly describe how these headings are really populated into this note.
Could you say normally we have physical examination comes after the actual history? It seems like an odd order there. I don't know how...
So that's something we can definitely discuss in regards to the order of the headings.
Okay. Yeah, I wouldn't put the BPS up top.
Okay. Is everybody able to see this screen clearly?
Yep. Again, a little challenging, but it is just about legible.
So what we have is our advanced care planning and goals of care component. So this is where there's two forms attached. So we have our advanced care planning. So if you were to fill this out and just click submit, this would kind of flow into this component. It's slow, and it would also kind of flow into this text format. And then same with our goals of care discussion. This is a form that's kind of attached to this component, which filled out, it would kind of populate into the note as well, and it's kind of documented as a goals of care text format. So what we have is our forms component. So this is where you have the adult pain and symptom management and palliative care power form. So this is where your bowel performance and palliative performance score will be documented and where it will get pulled from into the note. So your chief complaint, so this component is what we call a free text component. So you're able to document whatever you kind of would like to in here. So for example, I could insert something like test, and just hit sign. And that kind of is the same functionality for our history of present illness and physical exam. So I could just insert any free text and just click save. So for our vital signs and measurements, so the note will actually only pull in the last 24-hour results. So you won't get all these results from like the last 12 months or last 3 days or last 1 week. It'll only be the last 24 hours. So for histories, so a medical history will pull into the problem list and past medical history heading on the note. So where it'll capture the active problems, which are labeled here as chronic problems, and then the historical problems, which is your resolved problems. So for example, I can add kind of a problem here. I could add maybe pain to the back. And then it just got added here. And let's say we have a resolved problem. So let's say this patient doesn't have pain in the jaw anymore. So I could click that and just click resolve. And it would fall into your, oh, sorry, it's a little slow. It would fall into your resolved problems. So also what we have is our surgical history and your social history. So for these two components, basically information is visible here, but it's actually documented on the histories tab on our menu bar. So this is where you kind of can see your family history. So this is where you can add any family history issues. And then also your social history as well. So if the patient, for example, had kind of an social history related to alcohol, you could just click this and just enter any data that's relevant or applicable. So what else gets pulled into the note is both the patient's current medications and their home medications. And then you have your standard kind of allergies component. So this is where you can add an allergy. So for example, if the patient had an allergy to peanuts, I could just add that and save. So your assessment and plan component will actually pull in any issues that have been documented for as this visit on the active issues component. So as you can see on this patient, we have two kind of problem names and they're categorized as this visit. And you can see that they've been populated into your assessment and plan component. So for example, if you don't need these kind of problem names in your assessment plan, you can easily remove them just by hitting this X. Or let's say you do need this one kind of problem name in your component, what you can do is just add any further information. So you could just say it's mild or severe. And in addition, there's also just a completely blank free text box as well. So the note won't populate labs and diagnostic results itself. So you kind of have a couple options if you would like to include these kind of results. So one is what we have called the tagging function. So for example, if you want to include the calcium result, so what you would do is you just click on the result and you could just hit tag. Or another option, what you could do is just right click on the result that you would like to add to your note and just hit the tag kind of pop up. The same goes for diagnostics. You could just open up kind of the file. And let's say I just want the summary and conclusions portion. I would just hit tag.
So you're right clicking there. You highlight and right click?
That's correct.
Okay.
So now that I've kind of documented all my relevant information, I would like kind of being pulled into my note. I will go ahead and kind of open the note up. So just ignore this step that I'm doing. So what you can see is that all the relevant information that you've documented on the outpatient chart has been kind of flown into this note. So for example, your chief complaint and like your scores, your history of present illness, your functional history is actually just a free text component. And then your physical exam has been populated. And as I mentioned, so for when you take your lab results, what you can do is just kind of drag it into here and then it will get populated. But you also have the option of just free texting anything in as well. So you could just do test. And then you also have a third option, is what we call auto text. So what you can do, and what I've done, is just created an auto text that is inclusive of smart templates that will,
Right.
no worries, that will just kind of capture the labs categories for the last 30 days. So I can easily insert that by just doing comma, comma, pain symptom management, and just inserting the lab results for the last 30 days. However, on this patient, there's kind of no results that have been captured for the last 30 days, so it's been displaying as no qualifying data available. And then as you can see, the pain back that I added kind of got included, and the pain jaw got dropped down. And then for this patient, they currently don't have any current medication, so it's just showing your home medications and your prescribed medications. And the same functionality again for your diagnostics. You can just drag your kind of results in. And you also have the option of free texting and adding auto text. And then you have your assessment and plan component. So it's a very comprehensive kind of note that does capture a lot of information. But what I would kind of like to confirm today in regards to the design of this note is just kind of confirming that the bowel and the palliative performance score and the advanced care planning and goals of care kind of headings are necessary for this outpatient clinic note for the pain and symptom management palliative care clinics.
That's correct.
That's correct. Okay. And then I guess if so since they are, we would just like to kind of go over the placement of the headings. So what would be kind of ideal heading placements for these, or I guess the structure in terms of the headings?
I would normally, I'll get my Chantal and Marcy, let me know how you feel about it, but I personally would do them after having done the history, the bowel performance scale and the palliative performance scale would go after the history.
Okay. And then advanced care plan and goals of care, that's okay after chief complaint?
I would probably put it after the social history.
Oh, the advanced care plan. Okay.
I think I would incorporate it into that section. I usually do social history and then advanced care planning and then go into the physical exam.
Okay, so from my understanding, so we'll have chief complaint. So do we want to move up social history then?
We want to move medical history. The medical history needs to come up to be after the chief complaint.
Okay.
Are you okay with this, guys? Chantal,
Yeah.
Marcy, yeah, do you do this much?
Yeah, I'm okay with it.
There's an element of personal preference, but I think the kind of convention is that you have the history of presenting complaint, then the past medical history, and then you go into the social history. Then you do the drugs, the medications, and then usually a social history. Then we would put in the advanced care planning, then the medications, and then the examination.
And then the physical exam after that. Okay.
Yeah.
And then what about our allergies?
That goes after medications.
Oh, we go after medicines. And then your procedure and surgical history?
That's part of medical history.
Okay, so we'll include that together. And then what about diagnostics and imaging investigation? Is that okay near the bottom of the note?
Yes, I guess that would come after examination.
After the physical, okay.
Exam, yeah.
So after physical exam. And that's both diagnostics and imaging investigation.
Yeah, I mean, to be honest, I don't normally put those in a separate category. I don't list them separately. I include them in my introductory statement about the presenting complaint, like when I discuss what the presenting complaint is all about, because that's really what you're seeing them for. And if the imaging is relevant, then I will put it in there. I wouldn't normally put it in as a separate section.
Yeah, so an option that you have actually is just to remove the heading then if you don't want that. And if it's not documented against on the note, once you sign the note, it'll actually drop off as well the heading. So I know there may be some additional headings that won't be used, so that's just some couple of options that you kind of have.
Yeah. Chantal, Marcy, do you use a separate heading for?
I'll have a heading of investigations because I'll put lab work down there sometimes, like creatinine, and then I'll put them all lab, imaging that's pertinent if it hasn't been mentioned above.
Yeah.
But it's usually just lab work that ends up in there, but I just call it investigations and list whatever I think is pertinent to this consult.
Yeah. Yeah. That would be how I would do it as well.
Yeah, that's how I do it too. I usually have a heading. This is actually generally quite similar to the template that I use. I use a template on Fessor now anyway, and it's quite similar to this in quite a similar order. I usually just put pertinent diagnostic imaging or pertinent diagnostic tests or something like that, I think is investigations, so that it just is the catch-all like that.
Yeah, I would usually put like relevant investigations or something if I hadn't already included in the narrative, which more of and then not. If it's relevant, I put it in the narrative rather than like in the history of presenting complaint rather than elsewhere. But it's just quite nice to have that option, I guess.
Okay, good.
Yeah, I do make sure and put pertinent. The same under physical exam. I don't generally do, I don't know. I feel like just having physical exam there makes it sound like it should be a full physical exam every time. But I just do a more specific or like pertinent physical exam.
Are we able to personalize these later where you make your own template? You can make a couple switches and then it's always the same for you?
Yeah, so what we have is called auto text functionality. So you are able to kind of create these headings and just pre-populate it with certain smart templates. And then what you could do is just kind of open up actually I'll just show you. So what you can do is select other note. And what you could use is a free text note. And this is where you can kind of comma in anything that you would kind of like. So I think for like our transplant they have a kind of, they use an auto text. To kind of pre-populate a template. So you could do something like that. And that can kind of be done as well and will be explained kind of during the adoption kind of sessions. Jamie, can you just comment on that? Is that something you guys would kind of go over with the providers?
Yeah, absolutely. I will say some of the smart templates, like since we have this time now, getting that note that Anu's talking about now would be ideal. Because sometimes like the tokens that are pulled in for lab results or something may not be what you're looking for. We have a little bit more control, I feel, over like the overall template here, whereas AutoText doesn't have quite as many options, but it's good for adding to like a template like this or something.
And you had said it was still Fessor that we would be using with Cerner, like with this. So we'll, like if we already have automatic commands with Fessor and templates, will we be able to use those with this too?
Yeah, there is like a process of getting that moved over, and I'd have to talk to the Fessor team to know exactly what that is. But yes, there is a process for that.
Okay, thanks.
Mm-hmm.
Great. So are there any other additional kind of comments regarding this note? So what we'll do is we'll kind of take all the feedback that's been provided back and kind of rearrange the headings, and then I can send screenshots to you guys. And then if you guys could give any further feedback, that would also be great as well.
Can I just ask, so I'm just looking at this small print here. It says functional history, and then in the social history, which is a separate heading to functional history, you've got performance status. And I would only, that's duplication. Like where would we put functional status? I would normally put that separately and have social history as separate. But so within social history, are we expected to fill in those subheadings?
So that's getting pulled from the histories kind of tab. So what you could do is you could kind of, like if nothing's documented on that histories tab for social history, it won't get pulled into here. And then kind of you would have just a free text kind of option.
Yeah, but what I'm saying is if there's functional history somewhere else, or I'd say functional history to me is the same as performance status. So if is it going to auto populate the functional status into the social history, or is it going to auto populate it into a separate heading? I don't really care which. It just needs to be one, clearly one, and then people know where to look for that.
So functional. That's something.
I like having it there after the history of present illness. I think that's really useful for us to have that up top there, like fairly prominent, rather than hidden in the social history.
Oh, okay. So you like to have this information that's in the social history populated actually under functional history.
No, just the functional, just the performance part of it.
Oh, just the performance. Okay.
I don't want all of social history to go into functional history. It's just that they're two separate concepts.
Okay.
But the way that you have your social history example written up on the screen, the functional status is embedded within that rather than under the functional history heading. So it makes the functional history sort of redundant. If I'm correctly.
So maybe can we rename this then as to maybe functional history, or do you not want this additional information that's being pulled in? Like you only want, is it these headings as your?
I don't mind. You just have to have one, or pick one. Like don't have both.
Okay.
You got to pick one.
So functional history does have a form attached to it too, and I don't think you guys are filling it out because it's more of an inpatient form, like for discharge outcomes, just FYI. So that's probably why it's a separate header like that, because the form is more like PT/OT related type questions, bathing independently, stuff like that, which you would typically expect to see in the functional history. I don't think the activity, honestly, is being documented too much in social history. The good thing about the social history component versus that functional history component is it is patient level data. So anything documented in that social history follows the patient throughout multiple encounters. So if you document something in that social history, like their tobacco use, and they get admitted inpatient, all that information will be seen for inpatient. Whereas I don't think the functional histories, you'd have to go back and look at that form to see what the previous documentation was. But just an FYI on those two components.
Okay, in that case, can you take functional history out? Because that's going to mislead people into thinking that if they've put something in there, then it's documented for the future users. And if it vanishes as soon as they close it, and the future users can't see it, there's no point doing it there.
Yep, for sure.
For us, anyway. And once we get used to the fact that we're supposed to put the functional history into the social history, we can work with that. We just need to know, that's all.
I'm curious, why in past medical history do they split it into past medical history, then historical past medical history, and then surgical history? I've never seen somebody do that before, or say a myocardial infarction is resolved.
Yeah.
Can it just be past medical history?
Yeah. I would entirely agree. I'm sorry, I can't read that's just too small for me to see. My husband's left me a voicemail about what he's done with my cable. I'm just going to listen to it if you don't mind, so I can find out where he's put my cable.
I think too, for that header, like if you don't want to see past medical, I think anew we can take that one out. I think the header is just, it's being a little misleading because it's including their current issues as well as their past. So that's why it's kind of broken out into two. Like the top list is their actual problem list versus that historical is their past medical. So
yeah, usually that section's just past medical history and it has everything that's pertinent medically to them in there, including surgical and everything. So there's just one title, everything they got medically wrong.
Gotcha.
Yep, that's something we can definitely change. Anything else in regards to this?
I might be missing it just as you are scrolling, but I usually have a review of symptoms or review of systems header, which is actually pretty helpful to me because often they do not tell me about, bowels or memory problems or
That would normally
other
come
things.
after the medical history.
Mm-hmm.
I do too.
Yeah, it's a really good, like, I use it really as just like a reminder.
Mm.
So the only thing is, I don't think so I guess you can free text it in. It's the only thing is the review systems component is not on the outpatient chart. So you would have to kind of free text it in, won't be auto-populated.
And we do have, so under that physical exam, Anu, can you type in, like, we do have some review of system auto text built, I believe, for the providers.
Let me search it up.
Yeah, I thought it was ROS too, but maybe not.
All reviews.
There's a short review of systems as well.
Yeah, there you go.
If you could do a short review for follow-ups and a complete review for new patients, that would be excellent.
Yeah, and these are already public, so if you like the way these look, you guys are more than welcome to put those in. Or if you want to create your own auto text for review of systems, we can do that too in the adoption sessions.
Yep, so that's something to take back. And then you do have the options, of course, yeah, to include the auto text in. Any further kind of comments?
Is what you've got on the screen supposed to be the final thing now, or are you going to do some more moving of it yet? Because we've not got everything in the right order yet.
Oh yeah, I haven't adjusted the order, so I'll take that back and I will send screenshots of that just to confirm before we proceed with doing any build or any further kind of changes.
Great.
Yeah. Okay, great. So
at the end, we've got assessment and plan.
Sorry, assessment plan. Yes.
We've got to the end bit yet. I think that's suitably loose, isn't it? That we can put whatever we want in there.
Yeah, that's the free text box. Yeah.
Okay, and we can dictate all the time through this.
Yeah.
Yeah.
Mm-hmm. Great. So Jamie, did you want to touch base on the conference note?
Yeah, did somebody else have a question? Okay. I just wanted to, and that's a good segue too, because your conference note or what you're documenting in there, I didn't know if this template would work for that or if we needed to discuss maybe an auto text that's shared with everybody, which, like I said, we can do in the adoption meetings as well. I just kind of wanted to get that workflow for when you go to conference and come back in, like when you're charting, what that looks like, or if you need any additional headers or information in there.
Are you talking about a family meeting conference with patient and family, or a minimally invasive palliative procedures conference amongst health professionals? Because they're the only two categories of conference we do.
Both, actually, yeah.
Oh, okay.
And we do have like some conference already templates out there. I don't know, Anu, can you, yeah, just kind of show them what those look like for family conference at least. I just wanted to make sure we weren't missing anything documentation wise. So this is kind of just a standard, just with headers. It's not really pulling in anything. We can also do an auto text that you guys create, but you can just do in a free text form if you want as well. So.
Pretty good.
Okay. Awesome.
What about the physician conference note?
Yeah, what do you usually, because I don't think we have a template out there for that yet, but let's see.
There may be one that we can use from another context, save having to do something new. At the moment, all I've just got is a pre-saved heading on Fessor, and then I free text the whole thing.
Maybe the multidisciplinary, I don't know if that'll be, oh, that's very in-depth.
Yeah.
But we can also do an auto text too for those conferences as well, and just share that. What do you typically, is it usually just patient dependent, or are there specific things that you guys need?
No, there is a bit of a sort of a theme. So I mean, to a certain extent, there's similarities with the history, but for the minimally invasive palliative procedures conference, we have to have the underlying cancer diagnosis, and we have to have the symptoms, and then we would say relevant history. Relevant history, and then we would have the presentation of what the actual imaging shows, and then there would be the recommendations. Yes, because it's not really a plan; it's recommendations, and then there would have to be a follow-up plan, like what actually what intervention resulted from the conference. Like who's going to do what? Like who's going to send in the requisition and that sort of thing.
All right, we can definitely throw that into those headers into an auto text.
Yeah, I mean there are multiple case conferences that happen in the tumor group meetings, and I'm sure they're similar. Couldn't we just take a lung tumor group or whatever template and reuse that, or do you want us to do a separate one?
Oh, Fraser put in the outpatient clinic note. Can we look that one up anew and show that real quick?
Looking at that, I don't think the outpatient clinic will do it. There's too much stuff there that's not relevant. I think it's going to have to be a case conference template that is used and used elsewhere. Don't you have case conference templates already? Because each tumor group meets weekly, quite frequently anyway.
So these are the only conference notes that we have currently.
I can't read those. Can you make them bigger and then I can see what the choices are?
I can read them out to you.
Okay.
We have the confirmation neurological determination of death adult, family conference note, the ICU multidisciplinary conferencing for a complex patient, and then the multidisciplinary conference of complex patient note.
Okay, no, none of those will do. So I think this sounds like it's a cancer-specific thing that will need to be done for BC cancer, and it will need to be done by all different disciplines, not just us. So that needs to be flagged as a to-do, because everybody will need their own conference notes.
Do they all vary a little bit, or are they primarily the same?
They're all similar, but there are subtle variations. Like a lot of them include pathology, and ours doesn't.
Gotcha.
But they all include the patient history and the relevant investigations and the consensus opinion and the plan. So there are commonalities of the theme.
And we can follow up with the other cancer clinics too, as well, just to see if they're creating anything currently. And if not, we can still do the auto text until something is created. So I think that's all the questions I had with conference.
Thanks, Jamie. I'm just going to present my slides. So another outstanding kind of request that we had was regarding the outpatient quick orders. So the outpatient palliative quick orders have been updated, specifically the medications. So thank you, Dr. Hawley, for your input on that. So I know there's one point raised about referral orders, specifically if being referred to this clinic. As it was mentioned that the pain and symptom management and palliative care clinic internal service is combined and it's not either or. And currently, we just have referrals to pain and symptom management, and then we have a different referral to palliative care. So, which may make people think there are two different internal services. And I know you had mentioned that we need to really clearly differentiate internal pain and symptom management palliative care referrals from external referrals to community palliative care and hospice services. I'm just wondering, is there anybody on the line from ambulatory team that could comment regarding this?
It's Pat. I can kind of comment. So the order for the referral to pain and symptom management, that would be an internal order to refer the patient into the clinic, to the pain and symptom management palliative clinic in BC Cancer. The referral to palliative care order, that's live for both Lionsgate, Coastal, St. Paul's, and that's a referral that goes through the more so like inpatient palliative care. So if a patient came from emergency, they know it's a palliative, they need a referral for a palliative care doc to come down. That's what they would use to refer the patient to. That would be our internal order for a palliative care inpatient unit.
I think we just need to correct the terminology for our use, because as it's presented, because we've got a different structure.
Right.
That's a square peg in a round hole and will confuse people the way it's written now.
In the naming convention, you mean, Dr. Hawley?
Yeah.
Okay. Currently, the order for this clinic is, as it stands, referral to pain and symptom management without the palliative care part. Do you foresee that we should change it to more the abbreviation that is being used currently, the PSM-PC, or referral to pain and symptom management and palliative care?
Yeah, at the moment it's separated by a slash.
A slash. So you'd let, okay, yeah. So we could definitely do that. We'll change the order to note as referral to pain and symptom management / palliative care. Would that work? And that would be for the clinic. Yeah, it would be long, but like you said, it would be identifiable.
It might also be important to put an extra C on the end, so clinic, so to make it clear. I mean, we do actually, no, maybe not, because we've got our inpatient unit in the Vancouver Centre.
Yeah.
So it would be, whether it's an inpatient or an outpatient, it's still the same service, so that probably wouldn't separate it. Yeah, that's good. But then it is important to separate out, if you're going to be doing a referral to community hospice, that needs to be clearly community.
Yes, yeah. I believe I'll have to investigate, but in terms of creating an order for community palliative, I believe it would be a paper referral because community isn't live on Cerner yet. Okay, yeah.
But if there's two options and the one that is for external pops up with the form, or a choice of forms, because each regional health authority, in fact, each program within some health authorities has a different form. It would be fabulous if the appropriate form popped up.
Oh, I see what you mean for when it prints the paper referral.
Yeah, like
because,
I see somebody in Vancouver who lives in Burnaby, as opposed to somebody who lives in Richmond. I have to use two different forms for the palliative care referral, and most of the time the oncologists have no idea where these forms live. Yeah. It's different for Chantal, perhaps because she's embedded firmly in the Abbotsford, East Fraser Valley area. So, and Marcy, because they only have one health authority to work with, but I have multiple health authorities to work with, and it would be superb if we could just choose whichever form we wanted.
Right. I will take that as a parking lot item, Dr. Hawley, Dr. Chris, and Dr. Smith, and figure out what that form is looking like. But I understand what you mean, and we'll present that for validation.
Okay. Within Vancouver Coastal, there's Richmond, Vancouver, North Shore.
North Shore, yeah.
Yeah, that's the three.
Yeah.
But because
we have a different form for the North Shore, yes.
Yeah, we also have the Yukon from Vancouver.
Oh, okay, Yukon. Okay, I'll add that.
And there are some remote ones like Bella is part of Vancouver Coastal, even though it's way up north. And I believe that it might have a separate form as well. I'm not sure quite what forms they use, to be honest.
Okay, thank you.
I just got a patient referral from Haida Gwaii too, and have no idea what forms they use.
Yeah, I don't know whether Haida Gwaii. I think Haida Gwaii are still Vancouver Coastal.
Why
yeah,
am I seeing them? Anyway.
Yeah, I don't know why they would be coming to you. It should be either to Northern Health or to Coastal. As far as I'm aware, there's no link with Fraser Health from Haida Gwaii.
That's what I thought. Okay, good.
Yeah.
I'll get them to look into it. Thanks.
Yeah. Maybe they have family in Abbotsford or something.
Great. So we'll definitely take back the discussion around this, and we'll follow up. So next kind of item we had on our agenda was billing reports. Jamie, did you want to go into this?
Yeah, I can either share my screen or this is just very quick because I know there's a variety of different billing and you're not billing through Cerner. But we didn't get a chance to demo it last time, so I just wanted to make sure you guys had a look at it. Let me share my screen real quick. And this is basically just a report that there's a couple different reports that you can use if you want, and we'll go over this in the workflow review sessions as well. But it's just up here, and let me increase and it's just a report button up here at the very top, and you can, if you're managing your own patient list throughout the clinic, which some clinics are doing, some aren't, you can pull up your patient list here. Or most of the time we're just using this ambulatory report right down here. And I'm just going to do today's. And what this does is it's going to pull up anybody that I established a relationship with that day. And it gives you the numbers that you need in order to fill out, if you need to fill out any information on billing. So, and as you can see here, it does include, like if I've gotten into an inpatient chart, you can see that here. Let me make this a little bit bigger. But I just wanted to show you guys this as an option that you can use for if you do have to bill. There, that's what I like about this. And they do have the PHN numbers on here, so for you guys. Any questions or comments on that? All right, thank you, Anu.
So another item that we had on our agenda was just going to go over the pain assessment tool. So in our first design session, it was kind of mentioned that the current pain assessment tool in the adult pain and symptom management and palliative care platform differentiated from what is currently being used, which is the image on the left. Therefore, we kind of just hope to gather more discussion around this. Rosa, did you want to maybe jump in and kind of speak on this on the CST side?
Sure. So from a pain and pain scales perspective, one of multiple decisions for standardization the organizations had to make was which pain scales they would use and how those would be documented. And part of that is to ensure that as the patient moves through different areas of the hospital and or clinics, that we're gathering similar information that can be reported and monitored and all of those kinds of things. So as we look at the right screen, which is the Cerner build screen, what you're seeing there is as the design sits today, it's slightly, well, it's blurry, so I don't know if you guys can see it right now, but it's slightly different in what it's measuring compared to what is on your paper form today. But we wanted to highlight this difference so that way you guys could understand that if we go forward with the screening you guys are currently doing on the paper and then scanning it into Cerner so that way it's visible, they won't exactly match with what's currently within Cerner today in terms of what's gathered for pain as it sits today. Sorry, I'm just trying to focus on it, but I can't. I don't know if you can make it any bigger, or if this group has actually seen the details of it. Have you guys seen what the questions are that are in Cerner right now?
This is the first time I've seen this particular tool.
Okay.
We've discussed a number of other ones, and this doesn't look like what I thought we were going to get. This has somehow changed.
It's not that it's changed, it's what's already there in terms of what's just in the system right now. So I think the conversations we wanted to have with you guys are, does this capture the same clinical intent as what you're trying to capture? And if not, and if we need to escalate relative to, this has a different intent, then we have to do that escalation to add another pain scale. And we do that with you, with the other organizations to include it into our standard. But what you're seeing is just what's there right now.
And in some ways that there are, there's quite a different concept with this, which is a lot more complex than our simple minimum maximum average. This incorporates goals and activity, which is really great, but it doesn't give you the option to give a sort of range. Like it's only got a range according to activity, like a rest and activity. But it doesn't have much. It doesn't have an ability to say that there's a range for pain outside of with and without activity, and people's pains do vary. Like at rest, pain can vary quite a bit. See what I mean? It's got extra complexity, but it's kind of missing some of the basic stuff.
I agree. With this scale, it's the assumption that activity is the trigger, which for the vast majority of our patients is not necessarily activity, it's eating causes pain, or, there's so many other triggers other than activity. So having it focused on activity is odd for ours. I'd get it if this was an orthopedic clinic, but not otherwise.
So is the goal of what you guys want to capture specifically in it, other than activity, the at rest and the same things, like because we do have the basic like 1 to 10 pain scale in Cerner as well. I think we were trying to find the thing that matched the closest to what you guys are bringing forward, but there is the basic 1 to 10, 0 being no pain and 10 being the worst pain you've ever experienced. Is that, if we were just to move to having just that pain scale, would that capture what you guys are trying to capture? I feel like it's missing something too.
Yeah, it's missing almost everything. Yeah. That would be almost worse than having nothing at all.
So what would you suggest? So we would take it forward with you. So what would you suggest would need to be added in order to make it capture the same intent as what you're currently gathering? Or assessing for?
But I like the concept of having some measure of whether it's incident or not, but it needs to be not just activity. It needs to be something that captures what the trigger is if it's not activity. I mean, there's also activity it could be anything. It could be, going for a swim or going for, getting out of bed to go to the toilet.
Mm-hmm.
So I think we need to have something about what the triggers are that produce those particular numbers, and we need to have more of a range of pain, often dependent on the medication as well. Like sometimes people will have quite a range of medication, like they'll have an end of dose effect where their pain medication is wearing off. They're still resting. They're not doing anything different. They just need to take the pain meds sooner.
How's that being captured in the pink form? So we've only gone to the one little section of the pink form right now. How are you gleaning that information with the pink form?
With pain, we just do minimum, maximum, and average, as you said there. But then in the Edmonton classification system for cancer pain, it asks whether there's incident pain or not. So that doesn't specify what the trigger is. So it's integrating a separate tool,
which I believe we do have. Patricia, I'm going to turn over to you, but that we do have that.
I would like to present my screen to show you. Are you able to see my screen?
Not yet.
Okay. So again, this is the the adult pain and symptom management / palliative care power form, which all providers will have access to if required, also for nursing. Here we have multiple pain assessment scales that could be used. We have our traditional.
There's only one pain assessment scale. The other scales
Yeah.
are for other symptoms.
Yeah. So, and I believe that is why we can't produce the like for like, Dr. Holly, because this one, it doesn't mimic the minimum, average, maximum type of pain, but it has enough information to complete a pain assessment, that where you could create a pain comment if needed. There's also additional the same kind of type of assessment and for additional pain location, for secondary, a third pain site if needed, or just the regular numeric pain scale, which this is what you're seeing on the PowerPoint currently, but as you noted, it is about the activity.
Yeah, I'm not sure what's your question. What are you asking me about that? I don't think that will work very well.
No, okay, yeah, that's what I was wondering. None.
So
would you? Yeah.
I was just going to say I think you'd called out the Edmonton Symptom Assessment Scale being part of the assessments you guys are doing, and that gives some of the contextual. So I think she also just wanted to highlight that is there and available for us to, or for you to be able to use, or whoever's doing the assessment.
Yeah.
So I think that leaves us still with this question of that portion of the pink form and that assessment that you guys are doing right now. What does that need to carry over to become as we move to Cerner? So I think she's kind of shown you a bit of what we have to date. And I think what we're trying to capture is if none of those will meet the need, then what will meet the need? So that way, and then we'll have to do the escalation to move it forward.
Yeah, the bits of all of it are quite good. Each part of it, I can see why it's there and it's nicely done. The problem is that as a package, it doesn't fit the clinical context.
Sure. So what would help us get more to that clinical context? Is it specifically the questions as they sit on the power form, and then or on the pink form, or is there some other way we can tie these together a bit better to try to, document what you're assessing for?
Well, when you have the ESAS, if you can, with the pain section, that kind of needs to have pop-ups that appear, right? Like just having that 1, 0 to 10 for pain, unless it actually says pain now, which is inappropriate for an ambulatory care setting, is useless. So you could have all the ESAS questions except for pain there, and then have a pain heading that when you click on pain, it pops up and gives you the opportunity to do something in more detail. And I don't know how useful this will be to people other than us, but certainly for documentation of pain, we'd be lucky if people do anything at all, to be honest, because most of the time it just gets forgotten. But if we are going to have anything documented, it's going to be hard to figure out what that balance is between making it too complex and thorough to suit our needs in the specialist pain clinic, pain and symptom management palliative care clinic. A lot of what we do is a detailed, in-depth pain assessment. But people don't want that for everything. There needs to be a kind of a hybrid where we can have maybe a first level of exploration, which is not hugely complicated, like not including goals and things, but including things like what minimum, maximum average is and what the triggers are. I think that would be kind of my minimum. What do you think, Marcy and Chantal?
Yeah, that'd be good. I'd like to see something like that. And
so when you guys are talking about average, it's really a generally and historically, maybe not at this particular moment, but in the last week, kind of what was your worst pain, and in the last week, what was your, I just using week as an example, but it's that kind of assessment?
Yeah, I mean, if I can present you a picture, okay, so if you're walking around, you've been doing lots of cooking over the weekend, you have a little bit of backache, so maybe your baseline pain at rest is like 1, just enough to be annoying, but not enough to make you do anything. But then at some point, you dropped a big pan on your foot, and your pain was 10 for about an hour. Okay, so your pain score will go from 1 to 10. Okay, but that's going to look very different from somebody who is sitting at a 9 out of 10 pain because they've got cancer most of the time, except for 1 hour of the day when they finally gave in and took some painkillers. Like, so the range is still the same, but the average is very different. So you can't say that just having a range is enough, because you need to know where somebody is within that on most of the time. Like I would say, if I just dropped something on my foot, but the rest of the day I've been pretty comfortable, I'd say, well, on average, my pain was a 2. I mean, all of these things are a bit of inspired fiction, really, but I'd say my average was 2.
Right.
But then if my foot was in agony all day and I'm thinking about going to emergency, and I'd say my pain was averaging 9, and that it really is important information. That's what we use to decide how we treat people, like what drugs we write prescriptions for. That's what determines our prescribing patterns. It's critical.
Okay. So would you think of these 3 that you're talking about now in addition to what you're seeing in the build right now?
Yeah.
So you wouldn't get rid of any of those. You'd want all of them.
I would want all of them. So I would have 3 pain scores as part of the ESAS would be one way to do it. Or you could have pain as a pop-up, which takes you into a pain pathway, which has not just the minimum maximum average, but also has the triggers there as well, because that would actually be really useful information. And then you could have the option of having goals. Like, that would be even better. As long as not everybody had to fill that in, but if they did know what the patient's goals were, they had somewhere to write it, or at least that it would make them think, maybe I need to know what this patient's goals are. Maybe I can ask them about that. That would be a practice improving benefit of having the electronic charting system, because it would trigger people to ask the right questions. They wouldn't have to know that intuitively.
And is that typically, I would imagine that's typically done out of your practice as physicians versus, nursing or other practice of the others working in the clinic space. I'm trying to tie together your documentation and what I'm seeing here.
No, nurses could certainly do this. Pharmacists even. But definitely this is entirely within the purview of nursing.
Okay.
I'd say it's actually, it's not primarily, but for most nurses, when they're seeing patients in oncology clinics, I think they should be asking these questions.
I'm just trying to, the reason I asked the question, and I agree with you, being a nurse by background, I know it's definitely in my scope, more from if we were to put these pieces in nursing or another documentation, what would actually have to come forward to you as physician to know what had been discussed as part of that conversation is kind of where my brain was going. Okay, so
we also populated and I dragged in from the nursing notes so that there's no need for duplication. That would be really good. So we don't have to click on, because most of the time, to be honest, the nurses don't do it, or if they do it, they don't document it currently. So if we had to go looking in every set of nursing notes on every patient to see whether somebody had done a pain history or not, that would be very laborious and time wasting. So, in the majority of occasions, and every now and then you'd find a golden nugget, but most of the time there'd be nothing there.
And that's why when it comes to this, that's why the organizations have managed pain so tightly in terms of the documentation piece, because if we keep it clean and consistent, then it becomes easier to pull it into physicians' documentation, because we didn't scatter it all over the chart and make it incomprehensible. Okay, so what CST team, what I'm hearing is that the minimum, average, and maximum pain are not the same as what we have documented in the pain assessment that we have, the numeric pain scales portion that you have up there, and that it's missing some contextual information. So I think this is an escalation about whether this should be added to our pain, plethora of tools so that it can be incorporated in as part of the assessment. So it's an escalation we have to do. I have to warn you guys, we are on a very quick cycle of design, so we are going to escalate the decision, but I am a little bit worried that we don't get the decision in time to turn around the build, but we're going to do our best to make sure that that happens.
Okay. I mean, we've only been talking about it for 3 years, but
I know. It's like everything. For some reason, we're in a hurry up and wait and then run again type phase, but we will definitely be escalating that decision. So Pat will work together offline to escalate that, okay?
Yep, thank you. It looks like we are over time. Anu?
Yeah, I know we had just one other outstanding item. I don't know if you want to go over that quickly.
Yeah, Dr. Holly, Dr. Chris, Dr. Schmidt, is it okay?
I think Chantal might have gone.
Oh, okay. Well, the question was about your medical service that will be used in the clinic. So currently what registration team has identified is that there's pain medicine and palliative medicine. We posed a question to the other SME members, the non-provider SME members, but they thought that this would be more relevant as a decision for the providers as to, is this an acceptable medical service for the clinic?
Palliative medicine.
Palliative medicine, yeah.
Thank you. Okay, so we have that decision. And then I think there's just one more about the providers working in each site.
Yeah, that's wrong. So
No.
Vancouver's correct, but Kelowna's not.
Wrong.
Yeah.
Wrong.
And neither is Prince George.
Okay.
Marcy?
Yeah, that's wrong.
Would you be able to send us a list of your providers with the designations? Is that what you needed, Anu?
Yeah, that's just what we needed.
Yeah, it looks like, because I remember being asked to send mine in, and I did, but it doesn't look like you've asked the other sites. But
Yeah, I believe this is for access and provisioning, so that we're able to provide each provider with the appropriate access and provisioning for the system.
Yeah. So Marcy, if you can just look at the way that I've described the headings there.
Yeah. Palliative medicine, subspecialist, family medicine. Okay, yeah. So this would just be me, Mike, and Laura?
Yeah, but you'd be the same as Katrina.
Yeah.
Palliative care specialist, which is the CFPC terminology, not the Royal College subspecialty, because Julia has was family medicine background, but she has the Royal College subspecialty through the practice eligible route.
Yeah.
So there's one of everything there.
Okay.
Can you please do the same with the other centers?
Yes. So Anu, I guess we'll connect with the providers offline via email for the designations.
With the other centers, the 6
Yes.
centers, you've got the
Yes.
other 3.
We have Abbotsford, Surrey, and Victoria here as well. So we can connect with Dr. Chris about Abbotsford.
Yeah, but the others are all wrong as well. So
okay.
And
Yes.
Kevin hasn't started yet, so I would suggest going to Sabrina, Victoria, go to Sabrina Gustafson-Vickers.
Okay.
Sorry, Duanu Tamba, yeah. So Sabrina Gustafson-Vickers.
Okay.
Take it, and you've got it. I don't know why you've got an oncologist on all of those lists, except
Yeah.
none of those oncologists do palliative.
Oh. Okay. We will definitely clarify all of that then.
Yeah. I'll tell you for now, you can take Ursula and Jonathan and Jenny,
Yeah.
and Stacy off.
There is one more question we would like to clarify, Dr. Holly. This is regarding Vancouver Acute specific. It came about during the SME session. It's about your care aides transcribing workflow, where they're looking at the pink form. As a current state, they're looking at the pink form front and back, and they're transcribing information into this yellow form.
Yeah.
What we wanted to clarify was that in future state, what's going to occur for this your pink form is that it's going to live in an application called FormFast, which is connected to the Power Chart, where all forms that could be printed would live there, and this form would be printed by the clerk, given to the patient to fill out. And then what could happen to this at the end of the day is that it gets scanned into the patient's chart. It lives in the patient's chartlet and gets scanned into the patient's electronic chart, which could remove the need for the transcription part.
Okay.
As per what nursing has mentioned, but Zara was a little bit wanted to clarify with you if that was reasonable. Is there anything other information in here that you would like to live? It's just going to be the front part of the pain and symptom questionnaire. It's not going to have the back part of it, where you fill out the back part.
Yeah, I mean, the bowel performance scale and the palate performance scale are on the back.
Yes, which could be filled out in the Power Form now.
So they'll be somewhere different. I mean, it sounds like the information, most of it will be there. It'll just be somewhere different. The Canadian problem checklist.
Yes, is there as well.
So that's in the Power Form. Yeah.
Yes, it's in the Power Form.
So it's body map then, really. It's just the body map that you're missing.
Yeah, the body map we won't have the body map. We don't have the image, but the Canadian Product Checklist, the ESAS, again, the continuing conversation about your pain scale on this form, but overall, the rest would be represented in this Power Form. Okay. The issue is that the transcription, because our carries don't necessarily have they have limited scope in our system. So we were wondering, is it enough to have just this scanned into the patient's chart?
What about the fax data? Because we have direct entry into Oasis at the moment through the fax system. Can we not have that into Cerner?
Yeah, so that's what it's gonna appear like. So when this form gets faxed, it becomes a document, but it won't be a discrete data that pulls into your note. Does that make sense? Kind of like how Anu showed you.
You're talking about just loading it. You're just loading it up.
Yes, exactly.
To load up. But now what we do with Oasis is we fax it in, and the computer extracts the information and converts it to electronic data.
Yeah.
So we don't save the hard copy image. We only save the data.
That's what I'm wondering. And is that something that you still require that data to be extractable? Because if it's a form that is scanned into the chart, the data within it won't be extracted to pull into other notes.
Yeah, it makes it much more difficult for us to do chart reviews. I mean, it's a quality improvement and research tool, but at the moment we're not using it clinically, but I would much prefer it to be used clinically. That's why I'm so excited that with CST we might actually finally get a sequential ability to see the patient-reported outcomes, which is essentially all the information on the front of the pink form. It would be nice to be able to read that rather than having to request a data pool for research purposes. We'll be able to look at it in every patient all the time. To me, that's a big benefit of having it. But if it's no better, like it's just the same old, it's actually a backward step. I really don't want to just have just the hard copy in there. I don't think that's really a good use of resources, because it will be useless to us in terms of being able to.
Right now that we have, so when at some point in the future, the glorious future that we all ascribe to, a patient portal will become part of the scope of CST Cerner, and the patient will just be able to enter the information on a questionnaire that feeds directly into the electronic health record. But we don't have that right now. So what we're stuck with is the only way to get patient charted things into Cerner is the scanned, viewable as a PDF. That's all we have. So the only way to get discrete data into Cerner is someone has to type it into Cerner from this documentation piece. So hence where the transcription piece comes up. You're one of the first places we've encountered that has care aides doing that transcription or could be doing that transcription today. So it's another one that we haven't seen this workflow before. We haven't asked this question relative to care aides before. Professional practice has put limitations before on the transcription of information, but it doesn't mean we can't ask. I just don't know what that would mean for you if they came back and said no, which is part of what we need to have the conversation with you. So is it required that it be discrete and in Cerner to do the things that you're talking about, in which case there has to be a clinical resource who's provisioned to do it and resource to do it from an operational perspective?
That's a really difficult question to ask, really. You're saying, can we accept a reduction in the quality of information that we get? Well, we don't have any choice. We take what we can get. Like if we can't do it, we can't do it. You have to tell us you can't do it. And if you can't do it, then we have to accept it. But I don't want people to think that we think it's better to not have it.
For sure. Well, and what I'm saying is, from a technical perspective, there's no technical way to do it right now. It's a person way to do it. So we'd have to escalate it as people have to do this if it's clinically important.
No, that would be somebody else's judgment as to whether it was something that was important enough as part of the many competing resources. You're asking me to be the gatekeeper of the resources, which I don't feel.
No. I just want you to give us the clinical priority so that we can champion it for you, with you, and have that conversation with ops and practice. So what I'm hearing for you is it is important to have that data discreetly. So we'll escalate it and we'll ask the question together. That's all we can do.
Okay. Yeah, maybe just by escalating it, it'll at least create the expectation that this is something which is clinically useful. Mm-hmm. At the moment we use the pink forms on a daily basis when we're able to get them off the patients. We're not able to get them off them at the moment because of COVID, but we do use them on a daily basis, and it is useful. I don't think it's sensible to have care aides transcribing stuff. I think they can be doing much more useful things. So it's not that I want care aides to be doing this. I want a system which gives us the information as efficiently as possible. Whether at the moment our workaround is that we have care aides doing it because we've got no other resource, and the fax direct data entry seems to be the least burdensome of the administrative roles. But we do need to still have some process. I'm not saying that the process with the care aides is the best one.
So we'll work with this group around continuing that process, as it sounds like it's important. We are all for logging why the portal is important in the future and why people need to get it on board.
Yeah. I just worry that everybody's firefighting, and anything that's not top priority is probably going to be relegated and not happening. Mm-hmm. It's not going to be a level 1, level 2, level 3, level 4 thing. It's going to be level 1 gets done and everything else doesn't. Mm-hmm. So just out of pressure, there's only so much you guys can do. If I can put it at a level 2 priority, that would be my preference.
Thank you.
Nobody's going to die if we don't do this.
So we'll take the pain scales as the more important escalation, but we will put both forward.
Yeah, I think the pain scale, they're so related. Like if we're going to get the data, if we're going to get the patients to give us this information, it would be disrespectful of us to not then record it in a way that's meaningful, because then they'd have to just keep repeating it every time to different people. It does make a lot of sense to do it and document it well, and then you can review it rather than having to ask the same questions over and over. So retrievability of this data between visits is really, really important. And if you have to go back and open up a hard copy photocopy of something that's been handwritten on, I don't think that's really viable, to be honest.
Oh, hi. I'm so sorry.
Thank you, everyone, for your time. It's could. So next steps that we kind of have is our validation session. Patricia,
Yeah.
the 9 a.m., does that go until 12 then? Include the 1 hour for the providers?
Yeah, so for providers, sorry, it would be the 11 to 12
11, 12.
for the 1 hour validation session, right?
I've got it down as 1 till 2. Has it moved? Have you cancelled the 1 o'clock one?
Let me just double check. I have the ticket here.
Got it written down in my diary already.
I have it from 1 till 2 too.
1 to 2, okay. Apologies. We'll change that. Let me just double check. Okay. 9. We have it for 9 a.m. to 11 a.m. But you said that you have it for 1 p.m. 1 p.m.
1 till 2. Yeah, I can't do 9 till 11. I've got meetings from
Okay.
9:30 till 10:30.
We will note that on our ticket.
I think, in fact, Marcy and I have both got the same time, meaning that this has previously been scheduled.
Yeah, sorry. I think this is just wrong from our end. I apologize for that.
If it's possible to move it back to 1, that would be great.
Of course, yeah. Whatever time works best for our providers. Is there any other questions for us that you'd like us to review, or any other comments, concerns, feedback?
Well, kind of looking forward to getting it working. I think it's going to be really good when we finally get there.
Yes, very exciting times, definitely. Yeah, thank you very much, everyone, for joining us today, and we will see you virtually November 16th.
Great, thank you.
Yeah,
Thanks.
thank you.
Bye.
Bye. Bye.